Hello, and welcome everyone to our McFarland Clinic and Mary Greeley webinar today. The topic of heart health, what you need to know. My name is Shelley Jakey. I'm the Marketing and Public Relations Director for McFarland Clinic, and we're glad that you've joined us this afternoon. I'll be your host and moderator throughout today's webinar. Our speaker today is Dr. Stuart Christensen with the McFarland Clinic. He's a McFarland Clinic physician and cardiologist, and he serves in the Mary Greeley Cardiology Clinic. Before I turn it over to Dr. Christensen, some of the topics he's going to be covering include risk factors, prevention strategies, lifestyle changes that we perhaps need to make, and what are some of the new advances in diagnosis and treatment. So at this time, I'd like to turn it over to Dr. Stuart Christensen, McFarland Clinic cardiologist with the Mary Greeley Cardiology Clinic. Good afternoon, Doctor.
Good afternoon. Thank you, Shelley, and thank you all for joining us. Today, we get to talk about heart disease and heart-healthy lifestyles and prevention of heart disease, which is something I'm very excited about. I spend too much of my day dealing with the consequences of and complications of bad lifestyles, bad genetics, and bad decisions, and sometimes bad luck that have led to heart disease coming in. We don't get to see enough of the healthy patients trying to prevent disease. So we're going to spend time talking about how to prevent things. Heart disease is still the #1 killer of men and women in America. Despite all the technology advances and all of the new techniques and medicines we have to offer, it's still the #1 killer of men and women. So we need to do a better job of prevention so we can prolong good and healthy lives. So we're going to group heart disease into these different categories you see here. When we think of heart disease, a lot of us think of coronary artery disease or atherosclerosis, plaque buildup in the arteries. In that picture, you see the arteries running on the outside of the heart. There's 3 main arteries that supply the blood to the heart muscle. Even though the heart is filled with blood, the heart muscle is actually supplied through the coronary arteries. And so when people are having chest pain, angina, having heart attacks, often it's because of blockages in those arteries. And that's something that many times can be prevented by addressing risk factors. There's also a grouping of heart diseases called heart failure. We think of heart failure as a syndrome where you have increased shortness of breath, fluid retention, and often we think of that as from a weak heart, maybe a heart that's been damaged, you've had a heart attack or an enlarged heart, but actually half of heart failure is a normal size heart with normal function, but the heart just doesn't relax well enough. That's called diastolic dysfunction. It's actually 50% of heart failure is heart failure with a preserved ejection fraction, a normal squeezing function. But yet, even though the heart function is still good, it still carries a high mortality. People still die from heart failure in that regard. And then another category is arrhythmias. We've talked about the plumbing in the heart. We've talked about the structure and foundation. Now we also have problems with electricity in the heart. The heart has a pacemaker that's built into it that controls the heartbeat. Sometimes that can go slow. Sometimes there can be problems with the electrical signal getting from the top to the bottom part of the heart. That's called heart block. Those sorts of patients sometimes need pacemakers. There's also fast heartbeats, fast arrhythmias like atrial fibrillation, where the top part can go out of rhythm, can cause the heart to race, and can increase the risk of stroke. So that's more the electrical system. Now we can go to the next slide and we'll open the heart up and talk more about the heart valves. There's 4 valves in the heart, 2 on the right side, the tricuspid valve and the pulmonary valve, and then 2 valves on the left side. So blood comes back from the lungs with the oxygen in it, goes into the left atrium, goes through the mitral valve into the left ventricle. And that left ventricle is the main workhorse chamber of the heart. That's what really pumps the blood to the rest of the body. The blood goes out through the aortic valve to the aorta and then goes from the brain to the toes and to every tissue in the body. So 4 main valves. We spend most of our time focusing on the 2 valves on the left side of the heart because that's the main workhorse chamber and the high pressure system of the heart. Things like mitral regurgitation and aortic stenosis. And then finally, we also take care of congenital heart disease. There's groupings of congenital heart disease which happen early in life. This is something embryologic, something that people are born with, infants are born with. And some of these things, like transposition of the great arteries, need to have surgery immediately when somebody's born. But there are a lot of types of congenital heart disease that either are identified and are just followed well into adulthood, or are not even identified until later in life. Things like patent foramen ovales or atrial septal defects, little holes in the heart. Other people can have mitral valve prolapse or Marfan syndrome or bicuspid aortic valves. All of those are types of congenital heart disease that we follow in adult cardiology. All right, so a lot of those things we just talked about, those classifications of heart disease, especially the first few, like heart failure and coronary artery disease and arrhythmias, they can be prevented. I've seen figures that over 50% of cardiovascular events are due to a modifiable risk factor, mainly one of these risk factors. And if we could have addressed these things earlier, more than half of events, heart attacks, strokes, stents, more than half of those events could have been prevented. That's why we need to address this and have this conversation about heart health and prevention. So we all know these risk factors. We're going to go back to that slide for a while, Shelley. We're going to go through hypertension, which is high blood pressure. If we can go back. So the normal blood pressure is less than 130/80. We want to keep the blood pressure down. High cholesterol. We want to know what your cholesterol is, and cholesterol can depend on, whether we treat it or not, can depend on who you are and what your risks are. We have different categories. We have, so secondary prevention. If you're somebody who's had heart disease and you've had a stent or a heart attack, we know we need to get your cholesterol down. The goal LDL cholesterol is less than 70. So that's pretty low. Hard to do with just lifestyle, and often you need a medication to get that cholesterol down. But then a lot of us have high cholesterol and we haven't had a heart attack, and that's called primary prevention. And that's really what we're talking more about today. And so you have a high cholesterol. How high is high? Well, it kind of depends on who you are and what your other risk factors are. So a lot of times when somebody comes in a visit with me, we plug their cholesterol, their total, their HDL, and their LDL cholesterols, as well as their blood pressure and age and other things, into an algorithm, and it will kick out a number and tell us what your risk of cardiovascular events is in the coming 10 years. If you have a risk of maybe 1.5%, maybe you can just keep working on a healthy lifestyle and keep doing what you're doing. But if you have a 10-year risk of 20%, then we need to focus on addressing risk factors and maybe starting medications. The same can be true for diabetes. It increases your risk of cardiovascular events, risks of plaque buildup in the arteries. A normal blood sugar is less than 126. Normal fasting sugar, less than 126. And a normal A1C is less than 6.5%. If you're getting close to that number or getting above those numbers, then we need to address that. And this is a risk factor that can be modified very readily with dietary changes and exercise. Yes, a lot of people end up on medications as well. We have lots of new medications, but we can do a lot to modify our blood sugar with just lifestyle changes. If there is one factor on here that we can eliminate and take away, it would be smoking and tobacco use. That's very easy to eliminate. Hard to do if you are a smoker, but there's not much you can do that can increase your risk of a cardiovascular event by 6 times. But smoking can do that in females and by 3 times in males. It's just a tremendous risk factor. We don't have as many people smoking cigarettes, but we have more people using e-cigarettes and vaping, and that also increases the cardiovascular risk. We can group those next few categories together: obesity, nutrition, physical activity. We all know that by having a healthy lifestyle and working on those things, we can improve our cardiovascular outcomes. Knowing what a target weight should be, knowing what a healthy diet is, and getting some regular exercise is important. And we're going to talk about those more in a bit. Family history and age and gender and genetics, they can affect your cardiovascular risk as well. We know that everybody with a first-degree relative who has cardiovascular disease is more likely to have cardiovascular events themselves. But we already talked about how heart disease is still the number one killer of men and women. So most of us are going to have a first-degree relative who has cardiovascular disease. So really, when we talk in cardiology circles, we're talking about premature coronary disease. So if you have a first-degree relative that's a male that had heart disease less than 75 or less than 55, or a female less than 65, that really increases your risk of heart disease. And both men and women can get heart disease, but sometimes there's different factors that can play a role. Like hypertension is important on men and women, but things like diabetes seems to increase the risk of heart disease in women more than men, and low HDL in women more than men. And then finally, the stress and mental health. We know that things like depression, anxiety, poor sleep, mental health disorders can increase the risk of cardiovascular events, and they need to be addressed, whether that's through lifestyle changes, counseling, medications. All of those things are important ways to address those factors and reduce the cardiovascular risk. All right, now we can move forward. And we've been talking about cardiovascular events and a lot of these risk factors affecting plaque formation in arteries, which then lead to heart attacks or strokes or heart failure. We'd all love to have that artery in the picture on the left, the really pristine tube, the lumen with no plaque in it. But unfortunately, most of us don't. We start developing fatty streaks in our arteries as teenagers even. And those fatty streaks progress to plaque deposits. Sometimes those plaques get calcium deposited in them, and then they can grow over time. So we talk about number of plaques, we talk about size of plaques and the amount of blockage, but we also talk about stability of plaques. What is the composition of the plaque and how stable is it? Because what we don't want is that picture on the right side, the far right, where you see the plaque rupturing. That cap on the plaque opens, and all of that milieu in there, the white blood cells, the macrophages, all the inflammation pours out into the bloodstream, and all of a sudden it activates the platelets and you get a blood clot, and you go from perhaps a 20% blockage to a 100% blockage. That's why somebody can be feeling fine and be on the treadmill at the gym doing well, and then the next minute having an elephant sitting on their chest having a heart attack because a plaque ruptures and causes a complete blockage in the artery. So that's why we want to not only focus on the number of plaques and whether or not we have plaque, but we want to change the composition of the plaques. We would all like to be on the left. We want to avoid the stuff on the right, but the reality is most of us are going to be somewhere in those two middle diagrams. And we want to limit those plaques, keep them from getting larger, and then really stabilize those plaques so that they don't cause us any harm. So even if you have some plaque in your arteries, which many of us have, we want to stabilize that. So it's a little more, I think of it as more of a scar in the artery where it's there, but it's not going to do any harm, as opposed to an abscess that's angry and filled with white cells and ready to rupture and cause problems. All right, so then if that's our goal, how do we do that? How do we prevent that plaque from progressing or being unstable? Well, we can go in and get our regular checkups. Go see your doctor. I am required to see my doctor yearly, and I'm frustrated when my patients don't do the same. Now, you're on this webinar, so you obviously have some interest in heart health and you're trying to follow the rules. But it's important to get in, get your checkup, and know your numbers. You need to know what your blood pressure is. A normal blood pressure, as we said, is less than 130/80. Know your cholesterol so we know how to treat that. We can plug that number into that calculator and tell you what your 10-year risk of cardiovascular events is. Make sure your blood sugar's down and you're not becoming pre-diabetic or even diabetic. And then know your weight and body mass index. There's a lot of discussion about BMI. It's not the best measure of heart health. There's a lot of other factors, but it's easy to measure and it does correlate with cardiovascular risk. BMI is just taking the weight and indexing that for height and giving us a number. And then we can see whether that's healthy or unhealthy BMI. Yes, there's a lot of different body compositions and body types out there, and there's other ways we can measure things in more detail, but that's a marker of heart health as well. All right. So what can we do if we have some of those risk factors we've identified? What can we do about it? Well, one big thing is having a heart healthy diet. Again, you all know all of these things and they make sense, but we need to be reminded of it and we need to be motivated to do it and remember why this is constantly preached at us. I don't preach a particular diet. There are a lot of diets pushed on us, and a lot of it has to do with economics, culture, religion. So there's social norms. So different people require different diets, but a lot of them have the same core principles. The American Heart Association pushes the Mediterranean diet. The DASH diet is also heart healthy. We talk about a plant-based diet filled with fruits and vegetables. Some people focus on a vegetarian diet. They all have the same core features. Lots of fruits and vegetables, lean cuts of meat, limiting red meat, avoiding saturated fats, limiting sugars, limiting some starches, limiting salt. All of those things are focused on a heart healthy diet and limiting portion sizes. And then we need you to stay active. And that can look different for everybody. The American Heart Association recommends 150 minutes of moderate level activity per week. So that can be divided into 30 minutes a day, 5 days of the week. And that would be wonderful if you can do that. And that doesn't have to be at the gym, pushing it on a treadmill or signing up for a 5K. It can be working in the yard. It can be doing activity around home, or mainly just going for a brisk walk. If you can't do 30 minutes at a time, this can be broken up. 10 minutes 3 times a day. And even if you can only do 5 minutes, that's better than nothing. And then what I recommend is do what you can and then set a goal and say, all right, I'm doing 5 minutes today and I'm doing 5 minutes tomorrow. And then next week I'm doing 5 minutes twice a day. And then it's 6 minutes and then it's 10 minutes. And just stay active. It makes a difference. We can reduce cardiovascular risk in that way. We do still recommend 7 to 8 hours of sleep a night. Not enough of us get that much sleep, but that's what's recommended for good cardiovascular health. And then reducing stress. And along with that goes reducing alcohol use. I haven't mentioned that up till now, but alcohol can mess up sleep, even though I hear a lot of people say, I have a drink at night to relax me and so I sleep better. That's not true. Alcohol actually increases anxiety and messes up sleep. You're more fatigued the next day and you have disrupted sleep with alcohol. It increases cardiovascular events. And then maintaining a healthy weight. There are so many things we can do to maintain a healthy weight. Even eliminating, I've seen different figures, but eliminating 1 Pepsi a day can drop your weight more than you can imagine. Again, you can use the body mass index as a measure. We all have different body types, but setting a goal and going after that is important. And then we need to stop smoking, stop using tobacco products, including stopping vaping. And we do know that it's much harder for somebody to quit if they have somebody else in the household. It's better not to start, and we really need to continue to push people to not smoke and to not start, especially the young people out there. But we have lots of data, reams and reams of data and studies saying even if you've smoked for decades, there are benefits to stopping. And you can see those benefits within months, and those benefits continue to accrue 15 years out from stopping smoking. So we need to continue to work on that. All right. So we're going to spend the next brief time talking about early detection, a little bit on genetic testing, and then some procedures. So we already talked about getting a regular exam, doing some blood tests, knowing what your cholesterol is, knowing what your blood pressure is, getting some checks, and then knowing what the target numbers are. Then sometimes we have to go on and do more tests. Often we'll do an EKG or an electrocardiogram. That's just putting some patches on the chest and doing a heart tracing. It can tell us about the heart rhythm. It can tell us about the direction of the signal in the heart. It can tell us if there's evidence of hypertrophy or thickening of the heart. There are things called QAs, which can be markers for heart disease and prior heart attacks. But it also is like a fingerprint of your heart, so that we use that as a baseline. And then when you come in 5 years with a complaint, we can do another EKG and compare it to the one you had before and see if there's changes. And if there is, then that can be a marker that there might be a problem going on. Sometimes we need to go on and do an echocardiogram, not an electrocardiogram. They sound similar and are sometimes confused. But an echocardiogram is an ultrasound of the heart. That's where we bring you into a room, turn the lights down, have you lay on a table, and you just lay there and we do an ultrasound of the heart. You can look at the pictures on the screen sometimes as we do it, and you hear the heart beating, whoosh, 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 as the heart beats, and you can see the blood flowing through the valves. It tells us a tremendous amount of information about heart size, heart function. Is your heart enlarged or weakened or thickened? How is the blood flowing? Do you have holes in the heart? Do you have a leaky valve or a narrowed valve? Are the pressures in the heart elevated? A lot of that information could be obtained from an echocardiogram. We will often get an echocardiogram if you have symptoms, if you're short of breath, if you can't walk as far, if you're having chest pain or palpitations, or maybe we hear something on examination, like a skipped heartbeat or a murmur. That might prompt us to do an echocardiogram. We also do stress tests. The traditional stress test is when you get up on a treadmill, we have you walk, we watch the heart tracing to see if there's any evidence of blockages in the arteries or if the heart rhythm changes. We also see what the heart rate does during exercise and what the blood pressure does and what symptoms do you have. If you came in complaining of some chest discomfort, do you get that chest discomfort when you're on the treadmill? That tells us a lot of information. Some people need fancier stress tests where we actually do pictures while we do the stress test, either an ultrasound, an echocardiogram, or even a nuclear stress test. And if you can't walk on a treadmill, we can even do a chemical stress test with pictures where we just give you a medicine and look at blood flow or heart motion before and after the heart is stressed. We do a lot of calcium scoring, getting a scoring of the calcium arteries. This has nothing to do with taking a calcium tablet. If your primary care provider says you need to take a calcium tablet for your bone health, you should take a calcium tablet. Calcium in the arteries is something completely separate, but we do know the more calcium in your coronary arteries, the higher the cardiovascular risk. So just having a high calcium score does not mean you have a blockage, but it means you are at higher risk of having an event like a heart attack or a stroke over the coming 5 to 10 years. And we can take that score and compare that to other individuals of your sex and of your age and your ethnicity. So like a 60-year-old man may have a higher calcium score than a 30-year-old woman, but that 30-year-old woman's score may be way more significant because a score of, say, 25 in a 30-year-old woman is not that high of a score, but it's going to put her up at, I'm just guessing, at the 95th percentile for women her age, because a 30-year-old shouldn't have much calcium in her arteries. And if you're already developing calcium, then that's a marker that you have atherosclerosis and plaque buildup. And we need to address all those risk factors that we've already talked about, and maybe even think about starting medications earlier. So insurance doesn't always cover calcium scoring very well, but it's a test that can be provided by most medical institutions at a fairly low cost and gives us just another marker of future cardiovascular risk. And then we sometimes go on and do that last test on the list called a CT angiogram. That's usually ordered by a cardiologist. It's a little more technically difficult because the heart's moving and we're trying to do a scan and just time it every time the heart beats so we can put some pictures together and analyze things. But this not only tells you about the amount of calcium in your arteries, but also tells us some degree of stenosis. It can estimate, do you have a 25% narrowing or a 90% narrowing in your artery? And it's non-invasive. So it's different than an invasive angiogram where we put that catheter in your wrist and put it up to the heart. An invasive angiogram, you can put stents in. This is just a picture, and so it doesn't fix anything. And so sometimes we skip this and want to go straight to the invasive angiogram if we're really concerned about you having blocked arteries. But sometimes some of these other tests, like the stress test, say, well, it's a little bit abnormal, but I'm not sure. I don't think I need to put you through the risk of a big heart procedure, an invasive procedure, but I want more information. And that's when we'll also often order the CT angiogram. All right. We do offer genetic testing. We don't do this often yet because it's not covered by insurance many times, and we're still trying to learn how to use the information. The information is often used to help answer questions for future family members, and as well as for prognosis. So there's genetic testing for certain heart muscle disorders like hypertrophic cardiomyopathy. And some of these genetic findings, certain types of hypertrophic cardiomyopathy with certain genetics are more likely of having arrhythmias or sudden death or heart failure. So we can tell a little bit prognosis. We can also tell you about the risk of heart rhythm disorders like long QT syndrome. There's some families that have hypercholesterolemia, and we can do genetic testing and can check future heart members with genetic testing. And then certain congenital heart defects, such as bicuspid valves and things, can also be identified through genetics. Again, we're still trying to learn how to use that and how to have it covered through insurance and involved in primary prevention. All right, then finally, we want to touch base on some treatments and procedures. And really, this is a discussion for a whole separate lecture. So I'm not going to go through all the fancy different toys that we have, all the new procedures we have to offer, all the new medications, because we could talk forever about those. And those are exciting things. But I want to talk more about prevention today. And that has to do with lifestyle changes and medications. And then even if we find that you have heart disease, the core principles of lifestyle changes and medications are still what we focus treatment on. Sometimes we need to go ahead and do procedures. Sometimes we need to do the angiogram and put a stent in. Sometimes we need to go do an ablation to treat a heart rhythm problem. But often that doesn't change the underlying process that's causing the atrial fibrillation or that's causing the plaque buildup. And so we have lots of studies over the last 10 to 15 years saying stents do not help most patients live longer. It's the lifestyle changes and medications that help people live longer. And that's why it's very frustrating for a lot of patients, and even for some doctors, where we have patients that we know they have plaque in their arteries, and they even have an abnormal stress test, just mildly or moderately abnormal, but it's not a high-risk stress test. And we say, yeah, we don't need to go do anything more right now. We just need to work on lifestyle changes, and we need to get you on the right medications to stabilize the plaques, treat your blood pressure and cholesterol. We're in a society that wants the immediate fix. We want gratification, and we have the technology to do that. But the reality is, if we just go in and put a stent in every blockage that's there, it doesn't help you live longer, but it can cause more harm. Now, there's always exceptions to every rule, and sometimes we need to do procedures. If you are in the midst of having a heart attack, we will absolutely move ahead and get a procedure done immediately to improve blood flow to the heart. If you have a high-risk stress test or having troubles controlling an arrhythmia, we should do procedures. And we like to do procedures. But I want you to just understand it's the lifestyle and medications that affect things. I have some patients with stents that say, my stress test looked normal, but then I came in with a heart attack and needed a stent. I don't want another stress test. I want to do an angiogram every year, and I want to know what my arteries look like, and I want a stent if I have a blockage there. And I just say, I understand why you want that. We can't do that. That's not safe, and that's not right. So we want to continue to emphasize lifestyle changes and medications. They are the core principles of taking care of your heart. I am going to just stop there and allow us to go on to give plenty of time for questions and see what else these topics have brought up for you.
All right. Thank you so much, Dr. Christensen, for sharing your expertise. And we have indeed some questions that have come in that I'd like to share with you. One of the first ones is, why are older people subject to getting atrial fibrillation? Are older people, or why are they?
Yes. So atrial fibrillation, so the atrium is the top chamber of the heart, and it can fibrillate and go fast, thus atrial fibrillation. It often starts by an early beat just coming in from the veins that drain the blood back into the heart, and it just knocks the heart out of rhythm and the heart goes faster. As we age, there are structural changes in the atrium. The atrium can stiffen, it can enlarge, especially if we've had high blood pressure, if we're drinking alcohol, if we have sleep apnea. All of those risk factors that we have talked about a little bit, all of those things start to cause changes in the architecture of the heart, and it can lead to atrial fibrillation. Now, we see atrial fibrillation in 20-year-olds, in teenagers. It's common. It's a very common disorder, and we see it in young people, but we think of it as a degenerative disorder, almost like arthritis of the knees. It tends to progress over time, and part of that is use. Like in the knees, the heart just continues to beat, and there are changes with each heartbeat, but it's these risk factors building up over time. So that's why it just tends to happen more as we age, but it is a problem for people of all ages.
Okay. Next question, is alcohol a risk factor for the heart? I know you talked about alcohol affecting sleep for certain. Is it overall just a risk factor for heart disease?
Yes. The simple answer is yes. It can be very confusing, and you get a lot of mixed messages, especially over the last decade. At one point, there were articles out there encouraging people to have a glass of wine at night to prevent heart disease. Most of that literature has been found to be not true and not reproducible. I can tell you definitively that women drinking more than one glass of alcoholic beverage of any sort, or men more than two, can be harmful for the heart. It can increase the risk of sleep apnea. It can increase the risk of heart failure, weakening of the heart muscle. It can increase the risk of heart arrhythmias like atrial fibrillation. There is maybe some evidence that mild alcohol exposure, like having one drink a day in men, may reduce the risk of plaque buildup and atherosclerotic disease, but it is at the risk of worsening the heart failure and the heart rhythm. So, there's some different opinions on on rare alcohol use. But I can tell you, drinking more than a couple drinks a day is harmful, and it is safest to not drink alcohol at all.
Okay. Next question. In your professional opinion, is there such a thing as too high of HDL?
So, no. HDL is a protective risk factor. So HDL is the high density lipoprotein. It is the good cholesterol when we check the cholesterol panel. And we know that the higher the HDL is, the lower the risk of future cardiovascular events. Now, it's hard to get the HDL up. It's usually based on genetics. Some people are lucky enough to have HDL. In order for others to get it up, it's usually exercise and a healthy diet. We don't have medications right now. We were trying to create them, and it didn't work out. So we don't have medications that are very good at raising the HDL. As with all things, there are some exceptions. There are some genetic disorders that potentially can increase HDL and can be a marker of increased plaque buildup, but that is by far the exception. In general, a high HDL is a protective thing and a good thing, and we smile when we see somebody with a high HDL.
This question is, when is a cluster of irregular beats beginning or something to investigate? How is that determined, these cluster of irregular beats?
Yeah, so good questions. We see lots of patients with palpitations where you just feel some flutters or a fish flopping or something in your chest. And it's hard to know what that is. It's even hard for us as providers to know what that is many times. And we need, so there's certainly things we look for in history, but oftentimes we need to do more investigation, an EKG or a monitor to see. So one of the questions is, what is actually going on? Is it just a normal heartbeat going a little bit fast? Is it a normal heartbeat with just some premature beats, just a single beat here and there? Or it can be bigeminy, where it's every other beat, which can feel like a lot, but really doesn't necessarily mean that much as far as heart health. Or it can be a bunch of heartbeats that are together, and the heart can go race with that, or it can actually have a normal heartbeat, but just skipping, but not going fast. And all of those things are important and need to be addressed differently. So the answer to your question is it's hard for you to tell. If you're having palpitations, you should mention it to your provider. If it's just a skipped beat here and there, it's not as bothersome, and it's very common. Often can be related to stress and anxiety and alcohol and sometimes caffeine. Those can increase premature beats. If somebody has more beats when they're at rest and they notice it more, but when they go exercise, it goes away and they feel fine, that's often a reassuring feature. But if you have a question, you should probably talk with your provider about it, and they can try to sort through it with you.
Should or could we get a CT angiogram to understand where we're at? And they're referring to the slide that you showed that was listing the different kinds of diagnostic. So should they get one?
Yeah, so great questions. Not everybody should have a CT angiogram. We would all like that information, but the reality is it is a contrast that we have to give. It is some radiation exposure, and some people, we can tell through other means that they are at low risk of cardiovascular events. And so it would just be exposing yourself to risk that's not necessary. It's a technically difficult test, like we said. So they can only do so many of those because we need to give you certain medicines to slow your heart down. We need a heart rate less than 60 beats a minute in order to get a good CT angiogram. There's not enough scanners for all of us to get a CT angiogram. So some of it is just practicality and cost and risk. There are things, there's programs. If you go to Mayo Clinic has had their executive health program in the past, and they will do a CT angiogram often for their patients in that program because there is some utility to it, and you just pay a certain fee and they don't worry about putting that through insurance. They just pay the fee and do it. But I prefer to just focus on those patients that we think would benefit the most from doing that test and not just doing unnecessary tests. I think from the public health standpoint, we would be better off if everybody knew what their cholesterol and blood pressure were rather than everybody getting a CT angiogram.
Okay. This question, I'm adopted with no immediate relatives. I'm 64 and have about half of the risk factors. Would it be beneficial to have genetic testing?
Yeah, so that's a good question. We probably would not do much genetic testing for that typically. We would want to check your risk factors, your cholesterol and blood pressure and those sorts of things. Like we said, family history is just one factor in all of those things we discussed. And once you get to a certain age, and there's no specific age, but we talked about women less than 65 and men less than 55 being a risk. Cardiovascular disease is the number one killer. So basically, we make the assumption that most people have a family member with cardiovascular disease. Now, you know, if let's say you are adopted and we know that both of your parents died at a young age from cardiovascular events or something like that, that might prompt questions. So we might want to do some other investigation. But really, it would be focusing on some other features and then making sure we're getting your exam, listening to the heart, and knowing all the numbers. Again, the genetic testing is not done randomly or just for primary prevention for most people. Now, sometimes we'll do special cholesterol panels and things, which involve a little more additional testing, which relates back to genetics, but that's a little separate thing.
Great question here. Is cardiovascular disease reversible with lifestyle changes? We talk about preventing cardiovascular disease, but is it reversible with these lifestyle changes?
So yes, in many of these categories. Now, cardiovascular disease and heart disease, we talked about all of those broad categories. So it kind of depends what we're talking about. If you have had a heart attack and you have had a damaged heart muscle and a big scar in your heart, we're not going to be able to fix that scar. And that may have consequences down the line. So that's where prevention is so important. But yes, we have lots of people who have had a virus and have had a cardiomyopathy, a weak heart muscle, or postpartum cardiomyopathy where they had heart enlargement and weakening of the heart muscle, but we treat it with medications and the heart can get stronger again and your heart can go back to normal function. If you're talking about the plaque buildup in the arteries, that is mildly reversible. Once you have plaque, that plaque will not go away per se, but we have medications called statins, which have been shown to cause regression of the plaques. So the statins are the best medicines we have at causing stabilization of those plaques and then causing some regression. Now, by regression, we're not talking that those plaques will disappear. We'll talk that they will shrink a few percentage points. But that's why we push statins so often in cardiovascular health because of that. So regression, yes, reversible in some situations, and prevention, yes, for everything.
Is fish oil still recommended to improve cholesterol value?
Another loaded question. You guys ask a lot of great questions. So fish oil is good for the heart. It's just not good for everything else. Fish oil can make the platelets slippery. It can increase bleeding risk a little bit, and it can lower cholesterol a little bit. Not to the levels where we would typically want it to be for secondary prevention. So if you have heart disease, fish oil is likely not going to get the cholesterol down to where we want it to be. The concern is fish oil is shown to cause some other issues. There's urologic issues and cancer issues and some things that come along with fish oil. So most of us do not strongly encourage fish oil use unless we're really struggling with certain cholesterol things and trying to reduce atherosclerosis and plaque. But in general, eating white fatty fish a couple times a week is helpful. And I would focus just on that.
Question, what can I do to lower my A1C? Is it a slow process?
So A1C, just by definition, it's a measure of what your blood sugars have been over about 3 months' time. So it is going to take months before the A1C significantly changes after you make a change. But you can see changes. It's not years, it's not decades. And A1C will change. And you see that if you're monitoring it. And so, again, we have lots of patients that are borderline diabetic or early diabetics, and they change their diet and they increase their activity, lose some weight, and it can drop the A1C markedly. And often that should be done in conjunction with a medical provider that you do that healthily. What is a healthy weight for you? What is a healthy diet? What are the things in your diet that you can address to really address the blood sugars in particular? But it can come down. And then sometimes we do need to add medications, and we have a whole bunch of new medications that not only address the blood sugars, but also are shown to help cardiovascular health. All of the GLP-1s and the SGLT2 inhibitors that are advertised on TV now that can help with weight loss and diabetes and heart health are all some options that we are turning to if you're the right person for those. But I would start with lifestyle changes and just a healthy diet.
Okay. Question, should one not drink coffee if there's a heart problem? And I might expand on that question, just say, what about coffee or caffeine in general? But this one's asking about if you have heart problems, should you drink coffee?
Yeah, so most of the studies would say that, and there's some people that will shoot me for saying this, but most studies say that if people that drink coffee live longer than people that don't drink coffee. So coffee itself can be healthy. Now, everything in moderation. If you have heart rhythm problems, it can increase cardiovascular risk. Or if you have heart rhythm problems, caffeine can make your heart go faster in some people. It can raise blood pressure in some people. But in moderation, and if you're not putting too many extra things in with your coffee, it should not be the biggest risk factor, and it's not included on those other risk factors that we talked about.
Okay. What is degenerative heart disease? Individuals asking.
Yes, so degenerative heart disease can involve the valves. So it's just the wear and tear. Again, like we talked about with knees and arthritis, it can be the same thing for the heart. The heart opens and closes about 100,000 times a day for most individuals. And so the valves open and close 100,000 times a day. And so there's wear and tear on the valves. And that can just degenerate over time to where you get more thickening and more narrowing or more leakage of the heart valves. That can also happen with the atria, where you just get these changes in the atria and more thickening of the heart muscle because the heart's pumping against high blood pressure over and over again. And that's all degenerative changes. So it kind of is grouped in with all those other categories of heart disease that we had, as opposed to some people just have a genetic abnormality or some acute event or a virus or trauma or something else causing problems. Degenerative is just something that builds up over time.
I'm going to throw in a question. You were talking about the importance of sleep and the amount of hours that we should get. If you're lacking sleep, how is that affecting the heart? What's happening there?
So poor sleep affects a lot of those risk factors that we talked about. If you aren't getting enough sleep and good sleep, you're not getting into that deep REM sleep. If you're constantly being woken up, either you don't sleep long enough or you have sleep apnea or you drink alcohol or something doesn't let you get into the deep sleep, then you have more catecholamines around, more adrenaline, which then can increase the risk of having high blood pressure, increased risk of heart rhythm problems down the line, heart failure. So it's more, you don't get the deep sleep, you don't get the restorative rest and let all of your muscles and all the neurotransmitters settle down, the brain signaling changes, metabolism changes, and a lot of it has to do with the signaling pathways and neurotransmitters that affect the heart and the heart rhythm and heart muscle and all of those things.
Okay. A question here, if I have moderately high level of LPA Is it worth taking statins as a long-term preventative measure?
So that's a good question. A lot of discussions about LP little a, lipoprotein A. We have, you might see some studies coming out at the national meetings because there's some studies ongoing addressing lipoprotein A or LP little a, because there are new medications coming to address that specifically. We have not had good medications to address the LP little a. We are identifying that it tends to track with some of the other cholesterol numbers, but we also know there's some people who have a family history of heart disease, but yet all of these other traditional risk factors seem to be well controlled. And we're checking their LP little a, and they seem to have a high level, and that seems to be their risk factor. So the answer to your question is right now, statins are the best thing we have to address that. They're not perfect, and they don't lower the LP little a as much as we would like. The PCSK9 inhibitors that we have, the shots that you can take, they can affect lipoprotein A a little bit, but we're often not allowed to use those unless you've failed the statins. And then we have the newer medications that are in the studies now, which will hopefully be available in the coming years to more specifically target lipoprotein A. But the answer to your question is, if your number is high enough and you and your medical providers agree that it's a risk factor, starting a statin would be a good place to start.
One more question here before we start to wrap up. This individual is an orthopedic patient. Is there a heart risk associated with injection of steroid in the joints?
There is not a significant risk to the heart with steroids in the joints. We know steroids taken systemically long-term. So if you're taking prednisone for your arthritis or for your lungs long-term, can have effects on blood sugars and weight and composition. And that is more of an issue. There is not enough steroid absorbed into the system from like eye drops typically, or injections into the knees, or different things that would significantly alter cardiovascular risk. So I would not worry if your doctor thinks that a knee injection would help you be up and be more active and mobile. I would not worry about that from your heart standpoint.
Dr. Christensen, when would a patient see you? It must be a referral, I would assume. When do we know that we need to see you and your colleagues for your expertise?
Yes. So most patients would start with their primary care provider because we want you to be getting in to have your blood pressure checked and your cholesterol checked and your blood sugar, and have somebody listen to your heart. And so oftentimes the referral is sent from the primary care provider, and it may depend who that provider is. Some people feel more comfortable managing an elevated blood pressure or deciding when to start a cholesterol medicine. How high can a cholesterol be before we want to start a pill? When do we order a calcium scoring study? So some of those decisions you can make with your primary care provider. Some patients need to come on or just have other questions and want to address that with a cardiologist. And we're always happy to be involved in that decision making. And then often if we've identified a problem, if you have a family history of significant cardiovascular events, or we see evidence of premature plaque buildup or other things, oftentimes we will get you plugged in so you can follow with us and we can help you make decisions moving forward about best management plans. We often do require a referral just because we're busy. There's a lot of heart disease out there, and we keep trying to stamp it out, but we have not done that yet. We keep pushing it off to later and later, but people keep living longer and longer, and we still have a number of patients we're trying to take care of. So I would start with your primary care provider oftentimes and then discuss with them when an appropriate referral would be.